All right, good afternoon. We'll go on and get the meeting started. The Committee on Access to Quality Health Care will call this meeting to order. We are going to begin with a bill we've already heard some testimony on before, but it's had some changes that are fairly, significant in their impact, but pretty simple to explain. So I'm going to ask Chairman Hawkins to come on up to the microphone and we'll get you started.
Thank you, Mr. Chairman. Yes, there's been some discussion about...
Tell us the bill number and the LC
number. Oh, I'm sorry, yeah, it's 556, and you're talking about LC 1027. I got a lot of bills this year. It's 1027 is LC 338361S.
Thank you.
And this bill addressed the 80% of rebates being given to the patient at the time of sale. What the bill says now is that they shall offer an option to that patient through the insurer or the covered entities, which would be like the employer, of 80%. You know, with further consideration, obviously, the employer had to make the decision of maybe seeing the premiums go up versus the 80% at the time of rebate. So we're giving them that option. It's just an option. And then the second change in the bill is that the PBM will report to the Insurance Commissioner's Office on the number or percent of those who have opted in or accepted that 80% at the time of sale. And those are the changes.
All right. Members of the committee, are there any questions? That went from a mandate to now it's a mandate.
Right. It's optional. Right.
And it does. And then the simple other thing is a report. But
right.
So it does offer the option to rebate to the.
It'd be an option by by the insurer or the employer that has purchased the plan. Mm-hmm.
All right. Got a question, Representative Pirkle.
Mr. Chairman. When I'm looking at line 44 and you're looking at the option and the price is reduced to amount equal to at least 80% of the rebates received.
Right.
It has been my experience that if you offer an option equal to at least 80% of all rebates received, then you have effectively priced the maximum amount of rebates to be received to 80%. Are you concerned about that? We had talked about rebates on some of these drugs that the PBMs would retain 10%. And this, if you put it at least 80%, are you concerned that we have in effect hit a ceiling for the maximum amount that you will, by setting floor, you've also in effect hit a ceiling?
No, I think that asking for 100% of the rebate to go to the patient is even a better situation. I mean, you're in a situation of this. The patient goes to the counter, and if the rebates do not come to them, if it goes back to the insurer on the entire plan, it keeps the cost of the plan down. But how does that help a school teacher who's going there and having to pay $60 for a $10 script? I mean, I understand it keeps the whole plan, the cost of the plan down so the premiums don't go up. But for that single person, it doesn't help them at the time of sale. And I still believe in that. But with the atmosphere here at the Capitol at this point, I think the option of that occurring, the employer has the option to offer that to the enrollees under their plan, with the understanding that it may increase the cost to them. I think that's an option that everybody could live with.
A follow-up right
Sure.
quick, it's just in my past experience, and particularly like if I sell peanuts with a price to be determined later, and so I'll deliver the peanuts and they guarantee me at least $425 a ton by January. Every single time I have sold my peanuts for the $425. I mean, it's If I guarantee at least 425, every time it hits 425, and my concern is that in setting a floor, we set a ceiling. So that's just my 2 cents. Thank you.
Sure.
For the author, this is something they're offering, but the client is the employer, the one purchasing the insurance, right?
The insurer or the
and they
client,
can
which
choose
is
to offer zero and
Right.
retain have the rebates go toward reducing the premiums.
That's
just
right. It
requires
says
the
up to
people-
80% because obviously the higher you go on the percent, the more that the policy may incur a cost. It's like anything, any other health insurance. I mean, if you want to pay less when you go in, you got to pay more for the insurance policy. That's the way health insurance is right now, just general health.
Chairman Knight.
Thank you, Mr. Chairman. And to my friend, we've discussed this, but I just saw the substitute. I was trying to make sure there were a couple of things. Or one question would be, I see in the back of the language that, as far as the rebates, okay, it's a reporting requirement
Right.
for a percentage.
Or number or percent. Detail on line 47, detailing the number, and the percent of clients, right.
Yeah, but my point being is it's not an amount. It's just the number of rebates and a percentage.
Right.
But how are you going, with obviously the history of these PBMs, and the lack of transparency, and quite
Right.
frankly, some of the lawsuits that are going around the nation now, how would this, how could you come in and assure that that's happening? Because on 54, it says, in complying with the provisions, these benefit managers shall not publish or otherwise directly or indirectly disclose information regarding actual amounts of rebates.
Right.
So it's sort of like it's a percentage, but it's not an amount.
Yeah, you're right, that we're not tying them down like your legislation will. And hopefully if some of yours goes through, then this will be a help. But you're absolutely right.
Okay.
It's a first step. Let me just say that it's a first step.
All right. Since this is the second time we've heard this bill explained, and now you've explained the changes, what's the will of the committee at this time? I'll entertain a motion to pass.
I appreciate the time. Thank you.
Thank you, sir. Is there any other committee discussion at this time? All right. Is there I don't hear a motion on the passage of House Bill 1027 at this time. We will go on to House Bill 1032. Chairman Hatchett, if you can present it from there, we'll
Thank
get
you.
your microphone on. And
Thank you, Mr. Chairman. Ladies and gentlemen of the committee, you hopefully are looking at LC 338365S. This is the same bill we had, when did we meet? Thursday in committee. I took section 2 out. So the first section would permit, it's the same as a bill that's going through the Senate now, but it would permit a joint venture a joint venture with a Institute for Mental Disease, which is a private hospital that takes care of mental patients, has an emergency room, and allow them to go into a joint venture with a hospital in a rural county in the state. This section also goes through payment and reimbursement through Medicaid for these entities. Now, the new Section 2 involves, it's pretty self-explanatory, 44 on through about 50, but it will allow ambulatory surgery facilities that exist now that do not have operating rooms or don't have, they don't have non-sterile rooms. They exist as through a letter of determination from the Department of Community Health. There's about 50, 60 of these that exist in the state, and 2 years ago, because the department follows the Facilities Guidelines Institute's guidelines, they decided that these entities, the guidelines said that these entities couldn't exist anymore without a sterile operating room or an anesthesia room. But we have these here. There were no rule changes. It's just these guidelines that were followed by somebody not in this state. And what this will do is this change will allow these to continue to operate and will allow for more to be permitted. They are not part of CON because they haven't been part of CON because they had the letter of determination from the department. That's the bill that you're looking at that I have with sections 1 and 2. I do have an amendment at the appropriate time that I would like to discuss, or I'll take questions now, however you want to work that, Chairman.
Are there some questions for the author on the I guess the substitute bill that you're presenting? Are there questions right now? Yes, Chairman Parrish. Hang on.
I think I understood you to say that in this 8365S, the section 2 is not the section 2 that was in the bill we looked at the other day. Is that correct?
That's correct.
Okay, thank you.
Right, section 2's been omitted, and so section 3 became section 2, and then there's an amendment that might be offered. We do have some, any other committee questions at this time? We do have, Victor Moldovan, if you'd like to come up and speak, or speak from there is even better. Thank you. Okay, all right. And then Ms. Polvini, did I say that right? Polvina. Please, either from there or from the podium here would be fine. We are on a tight time schedule, so come on up if you'd like to.
Good afternoon. I'm Kathy Polvino. I'm here on behalf of the Georgia Alliance of Community Hospitals. And first of all, we'd like to thank Representative Hatchett for the changes that have been made in this substitute bill. So the only comments that we have are with respect to what is now Section 3. And our concern, well, was Section 3, is now Section 2. Our concern is that there are a few provisions in this, in Section 2, specifically lines 53 to 61, that are overbroad and go beyond the intended purpose. We understand that at issue are facilities such as pain centers and vascular centers and endoscopy centers that do not have sterile operating rooms. However, the last lines of this, of Section 2, which are now at lines 57 to 61, state that any facility that is exempt from obtaining a CON or does not require a certificate of need shall not be denied a permit under this chapter for not having an operating room environment as defined in the CON laws. The reason this is of concern is that since 1973, there have been consensus guidelines for the design and construction of ambulatory surgery centers and other types of facilities, including endoscopy centers. These consensus guidelines are privately published. However, they have had input from CMS, the Department of Health and Human Services, the American Institute of Architects, the National Institutes of Health, and the general public. So these guidelines cover things not just with respect to what needs to be in an operating room, but general things such as infection control standards, things like the type of flooring that can reduce patient falls. There are a lot of requirements about ventilation and other things that are important for surgery centers and other types of facilities. The last few lines in the bill as it currently reads, would exempt not just facilities with non-sterile ORs from these important requirements, but also all single specialty physician-owned ambulatory surgery centers and all hospital joint venture ambulatory surgery centers, because those are facilities that are exempt under the CON statute. So our concern is that those last lines of this bill would exempt not just 50 to 60 facilities from these important safety standards, but all types, 200 plus surgery centers that exist in Georgia. So that's the first concern. And the other concern is that we understand, again, that the operating room environment standards should not apply to facilities that don't have sterile rooms, but some of the other environmental standards, like infection control, protocols and environmental standards, are important to patients, and we would ask that they be considered as well. There are ways to more narrowly tailor this, and we would welcome the opportunity to work with Representative Hatchett and the committee to provide suggestions on how these could be narrowed.
Are there committee member questions for the presenter? Hatchett.
I did receive her comments and questions, and I would defer to the counsel of the people that brought this to me, who said he didn't want to speak earlier, but he may want to speak now. So, comments.
All right. Sure.
Any
Okay.
more questions?
Come on up.
Are there any questions from you?
No, thank you.
Okay,
Thanks
thank
for
you.
your presentation. If you just, as concise as possible to get your point across, if you don't mind. We are trying to
Yes,
get a
sir.
couple of.
I don't have the sub, but can I take a quick look at those lines and I can, thank you, sir.
So the concern raised is that it would exempt more than what the original target.
I'm fine if you wanted to strike lines 57 through 61. I'm sorry, it's 58 through 61, where it says any facility that is exempt, those lines can be struck, Chairman, and that we're fine with that.
Betsy? So, Chairman Hatchett, if you'd like to, well, we do have another amendment coming off to be offered, but you want to do?
At the appropriate time, I'll offer an amendment, I guess.
All right. Then, are there any questions? Representative Bentley?
Thank you, Mr. Chairman. I guess this question's for the author of the bill.
Certainly, go ahead.
It's my understanding from last week, the intent of this legislation was to address the mental health issue that we are dealing with in rural Georgia particularly.
Yes.
With all these strikes and recommendations and changes, is that gonna
The
address the initial intent that we're trying to accomplish?
Section 1 will help the mental health crisis. There's an amendment that I'm going to offer that will help with that. It doesn't do what I was hoping could occur, but I think it'll still help speed up that process slightly. So when the amendment that's on your desk will help that.
But for
So
right
it will
now,
address
we'll need
more mental health issues.
I believe we'll need at the appropriate time, we'll need a motion and a second to consider any amendments. Correct? Is that correct, Betsy? In consideration of the bill. So at this time, we need to have a motion and a second.
We gotta have a motion on the bill
We've got to have a
first.
motion on the bill first, and then we can discuss. Is there a second? All right, we have a motion and a second. Now I understand you may have two amendments now.
I think I do. If I can help me out, Betsy, the first amendment would be to delete after, on line 58, chapter period, delete everything after that.
That's right, that last
okay.
sentence, yeah, starting any facility.
Any facility that is exempt from obtaining a certificate of need or does not require a certificate of need shall not be denied a permit under this chapter for not having an operating room environment as defined in paragraph 27 of Code Section 31-6-2. So deleting that. And I'm okay with that.
So does everyone understand the amendment starting on line 58 with the word any? and proceeding through line 61, eliminating that. That's, I guess we'll call that Amendment 1.
Yeah.
Is there a, any other discussions on this amendment, Amendment 1? So that was a motion from, to amend by Chairman Hatchett. Is there a second for that, to amend that? Any further discussion? If not, all in favor of Amendment 1, striking the language starting on line 58, say aye. Any opposed, say no. Okay, that Amendment 1 passes. So considering on that bill, now, do you have a second amendment?
Y'all
you'd like
have
to
an
offer?
amendment that was given, AM 33-1940, and in line with what the representative asked, this is similar to Section 2 that was in the bill previously that would allow rural hospitals to take empty beds they may have and switch them to mental health beds, behavioral health beds, but they will still have to go through the CON process. They'll have to apply, go through all the requirements you have to go through, but if you read right there on line 15, the department shall not apply the consideration contained in paragraph 2 of subsection A of this code section. That subsection deals with proving that there is a need for this switch and for these beds. I think that we all know that we have a shortage of Medicaid-approved mental health beds across this state, and doing this in rural counties would open that up, and I don't think we should make a need that they have to prove that there's a need for those mental health beds in their facilities. But they'll still have to go through all the other process with CON that you have to go through, which won't really speed up everything, but that's the intent, is to get these hospitals to provide more mental health care.
Questions? I did have one. So was the goal of narrowing the CON exemption down to that one section, is that because all the life safety and staffing ratios that might be required would
Correct.
stay in place?
Correct.
Okay, but this would expedite it somewhat because no one could oppose it for lack of need.
Correct. Correct.
All right. We did have Chairman Parrish, I'm sorry, go ahead, sir.
I want to ask a question in the section 1A on the new amendment there that we've got. I understand that you're exempting this from proving a need to be able to do it, but under the other conditions of CON, can an application be denied?
Yes.
Under what conditions? Or
There's a multitude of lists, and I can't think of some of the attorneys in the room.
in other words,
Others could probably answer that.
it could still be denied if they didn't meet certain requirements.
Other requirements that are needed for
But
that,
it's
for the hospital.
exempting the proving that there's a need there.
That's
to
the
do it.
that's the only portion that this will exempt, is proving that there's a need.
Representative Bentley.
Thank you, Mr. Chairman. Can you help me, Chairman Hatchett, understand the process a little bit about going through the CON process? I know it's a long process, but just a little snippet of that as it relates to this, because the way I'm kind of picturing this right now is I think back on a conversation I had with a constituent about her son needing mental health services. In a situation like that, and there's no places in her neighborhood that has room for him, what can with this bill, if a hospital, as I referenced last week, hospital in Thomaston had the ability to turn one of those rooms, in an empty room in the hospital, into a swing bed, are you saying they have to, with this amendment, they're gonna have to go through a CON process to get approved for all of that before her son can utilize one of those rooms in that hospital as a mental health room?
Yes, they would still have to go through that process. What this bill will now do for mental health is it's going to incentivize joint ventures with rural hospitals, and it will allow a slight speed up of the CON process for rural hospitals to get to swing these beds from acute care to mental health. It's not doing what I hoped it would do originally, and I don't want to really editorialize my opinion on CON. I think most of the people in the room understand that, but I want to see a step in the right direction.
I think what concerns me when I hear the word slight speed up, because when I know when a family's in crisis and needs somewhere to place their family member that's having a mental breakdown, you know, how do I explain to them that it's a slight process? You know, this is a slight speed up, so. But thank you for answering the question.
Thank you.
If I might add, there are some special considerations with behavioral health, depending on whether they take 1013 involuntary assignments. There's special security, certain staffing guidelines. No one was ever suggesting that the security of the patients or the safety or infection control or anything else, that the portion of what we call CON that's really more life safety and staffing minimums and security protocols, those would still be in place. And I think no one's, but they just don't have to ask permission or prove a need, because what we found in behavioral health is that patients get transferred all over the state when they're in need of behavioral health services. So the local need may or may not be there. This is just a step to, my understanding was it's an attempt to give a little bit of preference to the rural hospitals to have some capacity and might be able to do this in a more expeditious way. It's not as fast as Chairman Hatchett, I guess, had hoped it would be, but at the same time, no one was ever suggesting safety and security protocols and things would be exempt. So it's a step in the right direction, I think, as the chairman says.
I'm with you, Representative Bentley.
But we are looking for ways to help our rural hospitals that are struggling, and I do believe there's a belief that this could be a step in the right direction to recognize that we need to make some steps to keep those alive, to keep the emergency departments open in those areas and letting them offer the services that they can do with excellence. Chairman Houston.
What is the cost involved in going through a CON process on this, like this?
I have no idea.
Because I know our rural hospitals are struggling for money, and I've heard that, you know, when you have people, well, I guess you couldn't object if need didn't come into effect. I don't know what the other things you could object on, because I know. And the next question, where did you build the amendment that you read out? Where did it start? On what line?
Starts on line 5.
It's right in between, well, you've got two parts of it.
Was it 53?
You gotta add a definition, and then you add on line 40 through 41. It says it in that amendment. It's got the instructions in the amendment.
Okay.
All right, so we have this amendment. Chairman Knight, did you have a question?
Appropriate time.
This is that time on the amendment.
I'd like, Mr. Chairman, I can make a motion do pass the amendment AM 331940.
Okay, is there a second? All right, we have a motion and a second on the amendment. Is there any other committee discussion? If not, all in favor of the amendment AM 331940, say aye.
Aye.
Those opposed, say no. All right, the amendment, now we have the bill on the floor as amended with amendment, I'll call it Amendment 1, and then also Amendment AM 331940. Is there any further discussion on the bill as amended? Correct, yes, we do. So we got a motion and a second as amended. All in favor of the passage of House Bill 1032, LC 338365S as amended, say aye. Aye. Those opposed, say no. The bill passes. Thank you, sir. All right. At this time, we will, let's see, well, we do have one more bill that we need a quorum for. 1, 2, 3, 4, 6. Yeah, we can have one. All right. I'll go on and present this bill as the author. It's House Bill 1105, LC 460318S. This bill is the Patient Protection Through Health Information Exchange Act. One of the things that we've had over the past really 15 years in healthcare is a growing recognition that paper records are an unacceptable way to deliver high-quality care. Billions of dollars have been spent of taxpayer money, along with hospitals' money and providers and others, to move that process further along. Much better legibility. We do have more and more pages of records that are increasing by the thousands. I reviewed a record recently of 6,500 pages. I didn't review it all. But what we're finding, though, is we still have, in spite of all the billions that have been spent, we have patients who show up in an emergency department, maybe unable to breathe, maybe unable to speak, and someone will mention that they were seen at another hospital or they were just discharged a few weeks ago or a few days ago from a different facility. One of the problems is the emergency care people, and it could be an oncology patient that had some studies done at another facility and now has a breathing problem or a other problem. What happens is that the providers there that would go in and admit the patient to ICU, or maybe trying to decide about whether a surgery intervention was needed, was there a brain hemorrhage, was it getting worse or was it getting better, but you don't have access to the records from the other facility. What House Bill 1105 would do would be to push strongly toward encouraging that for Georgia hospitals. There's certainly some great quality that can come from that, and in addition, it can help save having to, if you have immediate availability of pertinent information that's accessible through a secure site or a secure shared information portal, the patient can get better care. They can get it often less expensively because you won't have to repeat studies that may have been done in the past week or two. So this is something that's been attempted to be encouraged at the federal level. What we're looking at doing is doing two parts of this bill, really. Number one is collecting the information on how many of our current hospital electronic records vendors, how many of those systems actually do talk to each other in a patient beneficial way, not just a PDF with 400 pages in it, and call that information sharing, and not just the discharge summary that the patient may have been given from the previous hospital, but ways we can actually look at the real information on, say, kidney function or a CT scan result or an MRI result or an oncology treatment plan that was done at another hospital. So what we're looking for is what we would call robust health information exchange, where actually information that can help the patient. And I'm pleased to see this is actually proceeding, and there are some early attempts at this. What we're just trying to do in Georgia is to both put a spotlight on it by finding out what the status is of all the hospitals and their information sharing and how that's done in a secure way, but it's also beneficial to the patient, but also how we can advance that goal to where patients in Georgia will know that no matter what hospital they go to, if they're taken to in an emergency or even in just a shared treatment area, that the other hospital, the caregivers in that ICU or that emergency department would have access to their previous health information in a secure way. What we put in the bill is it'd be after next session, but it would be in July of 2021. Let me look at that. Where is it? Sorry, I'm looking for the actual line number. That after July 1st of 2022, I'm sorry, if you look on line 113, one of the teeth in it says that as a target, by July 1st, 2022, on line 113, we want, if someone's going to, if a hospital using a health system, an electronic health record, is going to participate in state health benefits, manage Medicaid, or our retiree programs, that they would utilize a system and they would encourage or require their vendor to allow the meaningful health information exchange that's referenced in the first section of this code about the interoperability. So that's the second point. First point is it gathers the information on where we are now by, I believe, by October of this year. And then second piece doesn't go into effect until, frankly, after 2 more sessions. What we're hoping to find out is give people plenty of time to plan ahead with their electronic record vendor to turn on these features, which are often part of the electronic health record. We'll be able to find out if there are funding problems with that, and it would give us 2 sessions to be able to fix that if we needed to help our rural hospitals, for example. I will say that requirement to use this does not apply, if you look at the very end, 117 and 118, it doesn't apply to a rural hospital in a rural county right now. We understand their resources are much more limited, and so rather than give an unfunded mandate, we certainly can look at the funding if needed in the next couple of sessions to where all hospitals are able to share, and when you're at your sickest, when you're admitted to a hospital, you'll know that that hospital and those personnel there have access to the previous tests that have been done, the previous records. So that's what House Bill 1105 does. We do have some people who, well, I'll be glad to open up for questions from the committee first. We have some people interested in speaking to the bill. Chairman Knight.
Mr. Chairman, I'm relying on you as a trusted physician in here, but part of, and again, you're the expert on this, and I like the idea of technology, and I like the idea of that technology helping our providers, being our physicians, and helping in the treatment with the patient. But I am concerned, I don't know the rest of the definition, maybe you can give me some hint, but this information, I like it when it's owned by either the physician or the hospital and the patient. But is this information being used anyway by the insurance companies? Because that data is it being exchanged and used?
There's probably others that can speak to that more eloquently. There's already a good bit of information that's available to the insurance company as part of the teamwork from between a hospital, providers, and the insurance company that already, especially if you have a contract with them. So there's already a certain amount of access, and the HIPAA Privacy Act is fairly robust about business associate agreements and how the insurance does have access to our health records to verify that the bill that they're going to pay on behalf of their client or their patient was delivered. So in a way that the insurance companies already have access to this information. This wouldn't really change their access. At this time, I guess we'll go on and start. There was a testimony from Tim Kibler.
Thank you, Mr. Chairman. Tim Kibler with the Georgia Alliance Community Hospitals. We are glad to work with the chairman to try to resolve the issue that he has presented. We appreciate the exemption for the rural hospitals that are ones that are most likely to have an issue trying to come up with the funding to address these interoperability questions. But we appreciate his reaching out to us to try to figure out a way to work with this, to work through this issue. And we have already committed to work with the chairman on this, regardless of whether this bill passes or not. So we're glad to assist in trying to enhance the access for a treating physician to the appropriate records of a patient. Mr. Chairman, we haven't talked about it, but maybe we ought to look at the patient that shows up in the ER may be as likely to have come from a ASC or a physician's office as from another hospital. So maybe we ought to look at looping them in as well. But thank you for your efforts on this front, and we're glad to work with you going forward.
Thank you. At this time, I'm going to turn the chairing of the meeting over to Chairman Hatchett to take us through the rest of this particular presentation.
Are there, we still got people to, okay. I can't read it. Tara Kramer? Okay.
Tara.
My name is Tara Kramer. Good afternoon. I'm the Executive Director for Gracie. We are a health information exchange organization in the state. Thank you so much for the opportunity to come today. My purpose today is really just to let you all know what we're already doing in the state, kind of the current status of health information exchange. It's not perfect, but I'm really proud of the work that we've been doing, and we still have some work to do. So Gracie is one of the health information exchanges in the state. We are the predominant HIE for I-20 and South. I would say we're the largest HIE in the state. We're very heavily concentrated in the Macon, Augusta, Savannah areas. Those cities have come really far in their health information exchange capabilities. So we have 23 different EMRs currently sharing information. So your Epics, your Cerners, all the way down to your Meditechs, to your amazing charts, for anybody familiar with these different EMR vendors. So we've done a good job with interoperability. Some of our limitations in the data that we're sharing, you have your large EMR vendors that are going to be very capable of sharing almost an entire medical record. Your smaller vendors are going to be much more limited in their technical capability. So I think that we're doing the best that we can on the systems that we have connected. We're going to be limited by what the vendors are able to share. Our specific HIE, we have 3 million unique patients in our system. The data dates back to 2010. So for those patients that are in our system, when they show up at different hospital systems, we also have physician practices included, ambulatory care centers, home health, hospice, nursing homes, all of that included in our HIE. So those patients are well serviced no matter where they arrive for care. But we certainly have a lot more than 3 million folks in the state, so we have some work to do from that respect. We have many organizations, many more hospitals are connected to HIEs in the state than even know they are. Meaningful use is something that CMS and the Office of the National Coordinator have been working on for several years, and regulations that they've pushed out to the hospitals. Those things are now tied to how hospitals and physician practices get paid. And so we see movement in that area, but it's movement because the hospitals and the doctors have to. And so a lot of times what we see, unfortunately, is the hospitals may implement a connection to an HIE, but the training down to the physician and the nurse level doesn't happen because they implement it in order to meet a requirement and not necessarily in order for the patient, for the doctors and the nurses to be able to benefit from using the HIE. I know that I'm trying to be cognizant of your time. Is there any questions that I could?
We do have a couple of questions, Ms. Kramer. Representative Knight.
Very quickly, is this data sold and monetized in any way?
It is not. It is not. Not in our HIE and not in the other HIEs that I'm aware of. Now, there is one HIE out of the Atlanta area, the Georgia Health Information Network. They do work with some of the payers with Medicaid, Georgia Medicaid primarily. So I know, for instance, the care managers for the foster kids through AmeriGroup have access to the HIE, but I think outside of that, it's pretty limited use cases.
Thank you. Representative Jones.
Thank you, Chairman Hatchett. Thank you very much for your presentation, ma'am. Do the other HIEs and do you integrate right now?
We do. We all share with each other. It is not as robust as I would like to see it when it moves from HIE to HIE, and that's because our systems work a little differently. So it works the best within your home HIE, but we certainly are pulling information from the others as well.
One additional question, Chairman?
Yes.
You said that you covered about 3 million of the other HIEs that you're integrating in right now. About how many do they represent of our citizens?
I don't know their number, but I could tell you that Atlanta is well connected for the most part. Everyone's using the same EMR system, so their vendor connects them. Outside of that, we've got good representation in the northeast corner of the state. You have Gracie, and like I said, south of I-20. We do have a good gap in the northwest corner of the state that we're all working together to try to address.
Thank you.
One final question, Representative Prince.
Thank you. What burden, if any, would this probably put on the rural hospitals, and because of bandwidth and things like that, sharing that information? Is that a concern at all?
I mean, as the author, I can speak to that in a way, but the burden, other than sharing their information, other than telling the department whether their system has interoperability or information exchange with others, that's section 1 of the bill, lines 117 and 118 specifically say it wouldn't apply if your primary campus is in a rural county. So that was a recognition that the resources, as you say, are pretty different. It's still a good goal, but it would not be touched by this
And if I could add that the cost really for any system is, well, the cost is going to be the barrier for any system. And it's not necessarily my fee. Our fees are extremely low compared to national standards, but the EMR vendors are going to have a fee that they're going to charge for the connectivity. And I've seen them up as high as $65,000 for a rural facility. Now, that's a one-time cost, but it's still a cost they have to budget for.
Any more questions? Thank you, Ms. Crane.
Thank you.
Next up is Bill Wiley. And if you can be as brief as you can, because we don't want to lose our committee.
Thank you, Mr. Chairman and members of the committee. I can be extremely brief with this. I would largely echo what the previous presenters have brought out to the committee. I was going to take this time to really brag on what our hospitals have done over the last several years in growing their, not reliance, but taking advantage of the technologies that are out there. The hospital community, as the last I looked, was roughly 90-something% committed to meaningful use. Now, that definition has changed over the course of time as vendors have improved, but using the most recent data, Georgia was actually higher than the national benchmark, and the only reason we were slightly below some of the surrounding states was the sheer number of rural and critical access hospitals that may largely report their meaningful use status through Medicaid and not Medicare. So largely speaking, that the hospitals have been very aggressive in doing what they can to meet those criteria and the programs as defined. I realize now that the rural hospitals have been exempted, but I can share a little bit about what we've heard from them from a program that we've got within Georgia, the Georgia Hospital Association, to really target them and not define it smaller than what they have to do, but really reach just to the immediate needs of the rural communities. Some of the challenges that they've seen, obviously, as has been mentioned before, is funding. The program that we have is very nominal to make a connection and send alerts back and forth. We had one of our hospitals that told us that their vendor was charging them twice as much as 2-year commitment to the program just to get a nominal feed of, quote, admit, discharge, and transfer data out. It's the same types of information that a lot of hospitals are using for payment, but just to get another feed was going to cost 2 times as much as just the participation. The other thing that we've heard, and this largely goes beyond the state to federal requirements, especially in the rural markets, they're looking at data to share around behavioral health and substance abuse. They're very conservative with the way that they share that information because of the Part 2 requirements that are out there. So hospitals in general, specifically around that, take a very conservative approach. But overall and in general, I would say our hospitals are very aggressive, very much trying to not only meet the strict requirements of meaningful use, but go above and beyond to meet the spirit and for the betterment of the patients. Thank you.
Thank you, Mr. Wiley.
Oh,
See any questions? Okay.
Not a question, no.
Okay,
Good.
thank you.
Can I
You
just
have
want to comment
you have a
on-
closing comment?
Well, I was going to, one thing that was mentioned about the Atlanta area having a good bit of information exchange going on because of a shared template. I know one of the things in the rest of Georgia that we've seen is there's a lot of transplants done at Emory and some other excellent institutions, but these people go back home. And even though the Atlanta area shares within itself, it can be extremely valuable to the rest of Georgia for the people who come to Atlanta for their care, and then they go out to northwest Georgia, as we spoke of, or other areas. It can be important that not just in that insular area, but if we can encourage and challenge all our hospitals to share information more broadly across their plans, not just within their proprietary system and the people who are paying. If we can encourage that, I think we'll be able to give a lot better care.
Thank you, Mr. Chairman. What is the will of the committee? We have a motion to pass and a second. Any further discussion? All those in favor say aye.
Aye.
Any opposed? Motion carries. Back to you, Mr. Chairman.
Thank you, sir. I believe that concludes our business for today. We may have a meeting tomorrow, a brief one. There's a possibility, but I will certainly let everyone know, and I know the conflicting demands on everyone's time.